meaning of life, and how does it apply to massage?
No.
Okay, well, fine. Yeah, oh, yeah, Miss Petrie, you're raising your hand. Thank you so much. We're raising both hands, electronic and real. Cool. Miss Petrie, yes, ma'am.
I do have a question, but it doesn't have to do with chapter 14.
Okay.
I actually would like to fire you.
Fire me? Wait, I'm recording right now. I've got this on tape.
Officially fired, sir. No, actually, on the test yesterday, you told me the wrong answer. Which means that other people may have gotten the wrong answer.
Wow. Let's go look this up. I'm so amazingly brilliant, I can't believe that I made a mistake like that.
I know. We were actually all very shocked.
Yes, thank you.
When I brought it up in class yesterday, and Mr. Ybarra said, "Oh my gosh, Mr. Tapscott got something wrong."
So was this a test on, what was it on?
It was on the adductors.
Yeah, I don't even see the test in my thing. Hold on.
It should be like test, is it 54?
Yeah, but for some reason it's not showing up. Hold on a second. It should be test 54. Oh, okay. Let's see here. Oh, Ms. Petrie. So some people got the test right, which means they didn't listen to what I said. I don't know if that makes me happy or mad. It means that some of you are smarter than me. Let's see. Let's go to the one you got wrong, Miss Petrie. Okay. Which muscle?
It was like number 22. I got two of them wrong. Okay. But I think it was like second to the last.
So I'm sure the book's right and I'm wrong. I don't have a problem with that. But I want to show you what I was thinking. Because,
right.
Because really, let's see here. Bear with me a second. I'm going to show you guys something. I'm going to share my screen with you. No, shoot. Cancel. Sorry. Present screen, window. There we go. That. There. All right. Can we all see this is the adductor magnus here. Can we see a picture of that? Can you see my cursor moving around? Good. Okay. I would have thought this was the adductor tendon. Right down here. Did you see that?
Yes.
Okay. They obviously mean something up here is the adductor tendon. I didn't read the book, by the way. I just looked at this and went, well, that's a tendon. It's off the adductor. I call it the adductor tendon. And your vastus medialis is right over this thing.
Right.
So based on that stupidity, based on the fact that I thought the tendon was here, it's right. But obviously, they're talking about some shared tendon it has up here or something. So I apologize.
It's okay.
Yeah, it's inexcusable. Anyway, I'm glad you actually pointed it out. I don't know how I feel about it because I really actually like my answer better, but that's just because I'm biased. Yes, Miss Monreal, do you have thoughts?
Well, I was oil pulling earlier, so I had like coconut oil in my mouth, so I couldn't talk.
Oh,
that was so difficult. That was so difficult for me.
Yeah, I know.
You
might have. Maybe you should do that more. What'd you call it? Oil what?
Oil pooling.
Pooling or pulling?
Both.
Okay.
Like
I think
people say it differently, but yes. Pulling.
And what's it supposed to do besides keep you quiet?
To pull the toxins out of your mouth and bacteria.
Oh, interesting. Okay. So, did you just want to share that with us? Or do you have something to say now?
I just want to say I'm so disappointed in you.
Oh, you couldn't share your disappointment along with Miss Petrie because you had coconut oil in your mouth. Yeah.
That was
I feel like we've hit a new low here.
Yeah. So I hope you're honored.
Yeah.
Okay.
Wow.
That's all.
Thank you. Go put a coconut in your mouth. Whatever. Anyway, thank you, Ms. Petrie, for pointing that out to me. Yeah. Bummer. Yeah. Okay. Any other mistakes I've made? Anybody else want to take a swipe at the teach today? Huh? Okay. All right. Let's see.
That haircut.
Yeah, actually, no
I'm
doubt.
kidding.
No.
I'm kidding.
Actually, I need a haircut, and it needs to be short. And when you're older, I think in a male, you need short hair and keep it clean cut. So, no, it's all right. Just jump on in. Go ahead, everybody.
I'm totally kidding.
I know, Miss Cooper. Let's talk about clinical massage, trigger points, fascia, orthopedic assessments, all this stuff. I feel like, these massage books start to kind of try to divide up massage in all these categories so they can talk about it. We've kind of talked about this with the human body before. I think almost every massage should be a clinical massage. So I think it's like special populations. Everybody's a special population, right? We're all kind of special, and so everybody should have special considerations. And I think that clinical massage really means that it's a therapeutic massage, and to me there is no other kind of massage than therapeutic massage. You're also always trying to produce some kind of therapy, even if it's just the emotional therapy of relaxation. But you will find that 99%, there are 1% out there, I've met them, but 99% of clients want some kind of therapy. They really do. Nobody wants to just be tickled for an hour. I mean, your kids do, I know that. But my point is, nobody pays $80 to $100 an hour just to be tickled. They want stuff fixed. And so I think every massage is a clinical massage. I want to just kind of start out this lecture that way. I'm going to try to go through this kind of quickly because I would like to actually spend time quizzing you guys on anatomy instead. But anyway, we can all see the slideshow right now, right? Somebody? Not? Okay. Clinical massage. It's the use of massage techniques to safely work with patients who have disease, disorders, or injuries. Everybody's got an injury. Everybody's got some disorder. But the point is, clinical massages have a treatment plan that's based on some type of therapeutic effect. Yeah? They throw in palliative care in here too, which I would actually not call a clinical massage, but that's okay. Can anybody tell me what palliative care is? Because it is very different from therapeutic massage. It can be palliative massage, don't get me wrong. But what's the difference between therapeutic massage and palliative massage? Anybody? So take a step. Miss Monreal, please.
Oh, sorry. I don't know if this is right or wrong.
That's never stopped you before.
Is it just to maintain? I don't know.
Actually, that was a really good answer, Miss Monreal. I wanted to give you a hard time, but that's a great answer. So, therapeutic massage, you are trying to make a change in somebody. Even if I worked on any of you and you said I don't have any problems at all, when I got to a tight spot in your body, I would make it a problem of mine, right? I'd be like, I'm going to try to make this a little bit better, right? Because I want you to feel better. So I'm still looking for stuff that's wrong. It's not wrong, but stuff where it's tight or whatever. So I'm always kind of thinking therapeutic massage, right? We're always trying to make an improvement. Palliative care, you are not trying to make an improvement in the client. Palliative care, you are trying to make somebody feel better, usually, but not always, usually at the end of life. Palliative care is where the massage is for emotional nurturing. It is not meant, and it's not always at the end of life, but it usually is. And so if you're 106 and you're getting massaged to make you feel better, I'm not going to be like, this is a good time for us to restructure your lower back and let's strip out your hamstrings and let's get your pelvic tilt right. No. This is a time to not even maintain, really. This is a time just to make you feel better. And that's palliative care. You'll hear palliative care that's palliative massage. Palliative care is anytime you're just trying to make somebody feel better. You're going to unfortunately hear this at the end of somebody's life where the doctors go, we're just providing palliative care right now and giving them morphine. They're not giving them morphine to make them feel better. I mean, they're not giving them morphine to make them better. They're giving them morphine to make them feel better before they die. Palliative care is just making somebody feel better. It is the approach we use too when people are in crisis. When somebody's in crisis, it's not time for me to say, well, Miss Yanez, you really should have thought differently about this and probably shouldn't have done X, Y, Z. I don't know why you're in crisis, but you are, Miss Yanez. She's in crisis right now. Right now is the time to be palliative. Like, it's going to be okay. I'm here. It's all right. It's okay. Let's get you safe. Let's do that stuff. Later, we do the therapeutic care, where we're like, what were you thinking, young lady? So palliative care, yes, is when you are just trying to make a client feel better. Therapeutic care is when you are trying to create therapy. You're trying to improve a situation. And I think you should know the difference when you're working on somebody. Like if I've had clients come in, I'm sure Ms. Petrie has too, that were regular clients where they come in sobbing and they've had a really bad day. And they are coming to me for therapeutic reasons in general, but I can tell that that particular massage is going to be a little bit more palliative care, right? They don't need deep tissue on the fact that they just lost, I mean, I'm just saying this because they've had it happen. Like they've lost their father, but they still want to come for their massage. This is nurturing time, which is also therapeutic. But my point is, you kind of decide, what am I trying to do in my massage? Most of your massages will be therapeutic. Most of your massages will be clinical. They really will. They don't have to be high-level clinical, but you're trying to just be like, oh, your low back seems tight. I'm going to try to make it looser. That's therapeutic massage. That's clinical massage. Cool. All right, I feel like I beat that into the ground. And most of your massage is kind of physical rehabilitation. You know, you're trying to get somebody back to the condition they should be in, the condition they were in before they had an injury. Or maybe it's not an injury. Maybe it's a lifestyle thing where I've been working at my desk like this so long that I'm kind of like this. You're trying to get me back to this. We'd like to go from here to here. That would be nice. So we're trying to rehab our clients. In clinical massage, though, especially you are. I'm skipping through a lot of this because it's not super duper important. Insurance companies will pay for some clinical massage, although usually you have to be associated with a doctor's office. And usually the doctor is sending in diagnostic code documentation, which is actually a medical kind of code documentation to get stuff reimbursed. If you ever work in this sort of situation, by the way, it's really cool. And you don't have to know everything to do it. Because the doctor will often be like, okay, here's the problem, and I want you to loosen up the hamstrings, and I want you to do these type of stretches on this person, because here's what I think is the problem. You learn a lot. They enter all the codes then afterwards, and if you ever work in this type of situation, if it's injury work, sometimes you don't get paid right then, you get paid down the road. And I have a friend who does this, and they don't get paid for a lot of the massage they do, but then when the court cases settle, they get paid this ridiculous amount of money. Because they charge something like $160 an hour for their massage, but it's all done up front because it's pro bono work until the case goes through and stuff. So just kind of interesting. Interesting stuff that you can do. Pain. Unpleasant sensory or emotional experience. Don't forget that pain is physical and emotional. And what we've really found, and not just me, I mean doctors, pain scientists, is that we can't really separate emotional from physical pain completely. Your emotional state affects your pain a lot. A lot. When you're in a better emotional state, your pain is highly reduced. When you're depressed, it's highly increased. And unfortunately, pain causes depression too. So they weave together. It's very hard to separate them. But it's one of the reasons that our massage rooms, that we really want to also be paying attention to the emotional state of the client and trying to make them feel as good as possible. Because it helps their pain get better. I am sure that I have had clients who didn't really get better because of my massage, in the sense that I hit the right spot, loosened the right thing. I think some of it was that somebody cared about them. They paid for somebody to care. And that might sound kind of lame. I think it's wonderful. And I've talked to psychiatrists and psychologists before who said sometimes people are paying us just, to be there for them, and it's very therapeutic and it works. Like, they don't have major problems, but they just don't have anybody to really listen and help process through them. You just being there for a client and caring for 1 hour or 2 hours is a big deal. That said, by the way, everybody, when the treatment ends, that time ends. You need to move on with your life. It's not that you're callous. It's that you need to now care about you now, right? Otherwise, there's nobody left to care about you. And if the client wants to keep talking about themselves after the treatment, I always tell them, even if I'm lying, I have another client coming. I want them to realize if they want to spend more time with me, they've got to book more time with me. Otherwise, you kind of get this codependent kind of thing going. So they pay for your time. If they want to sit there in the room and yap away at you while you're rubbing them, that's fine. But if they want to do it for 3 hours, they need to pay for 3 hours. Cool. Okay. Do we remember when we did the nervous system? Because this is an important word to remember. This is one of those things that massage therapists should know. They should know what nociceptors are. I know this says nociception here, but nociceptors. Do you remember that I said there's these wires, right? Your brain has these wires going to every part of your body. If they weren't going there, you wouldn't be able to feel those areas of your body. Every little spot. Thank you. So, at the end of those wires, I said there were sensors. They're very much like little switches, light switches. And there are different sensors for different things. Some sense pressure. Some sense temperature change, some sense rapid stretching, some sense vibration. And that's how you feel each of those things, is that sensor gets set off and sends a signal to your head and your brain kind of figures out what's going on. Nociceptors are also called pain receptors, and they sense intense tissue damage. So nociceptors go off when things are going wrong. You cut yourself with a knife, you get tissue damage and your nociceptors go off. And they send a message to your brain. And that's nociception. And your brain goes, oh my God, that's a nociceptor going off. That's 10 nociceptors. That's 1,000 nociceptors going off in my finger. There must be a problem. In fact, that's what makes stuff hurt more, is the more nociceptors that go off. If you just set off one nociceptor, you're like, eh. You set off 1,000, you're like, oh my God, that really hurt. Right? So that's nociceptors. Nociceptors are the receptor at the end of a nerve that are there specifically to pick up damage. And that's called nociception. So you'll hear people talk about nociceptors. In massage, we are trying not to set off nociceptors. So I'm trying to go deep on you, and it's okay if I set off your pressure sensors where you're like, wow. And I'm like, yeah, does it hurt? No, it just feels like a lot like you're sitting on my back. That's cool. That's not your nociceptor going off. That's your pressure sensor going off, and I am sitting on your back probably. So that's good. That's fine, but we're trying not to set off nociceptors, because when nociceptors go off, people recoil, they tense up, they flex, they do all sorts of stuff we don't want them doing. Plus, by the way, it can emotionally set them off. It's pain. Let's see. I don't know if this is really that important at all. I've said this before. This is a very fancy way for saying this. It's called the neuromatrix theory of pain. And let me just very simply save you a lot of time. The neuromatrix theory of pain says that, and I've said this before, that I don't really just experience pain. I don't just have a nociceptor go off and then feel pain. I have a nociceptor go off. My brain synthesizes and interprets what that means and then makes me experience pain. It says there's two parts to pain. There's nerves going off and then my brain's interpretation of what those mean. So you have to remember this. 1 second, Ms. Cooper. You have to remember this. When a nerve sensor goes off, my brain does not hear pain. My brain hears click, click in the index finger, nerve sensor going off. My brain then decides what to do with that information. If in the past you gave me chocolate every time you pricked my finger, eventually my pain would be like, oh, that's a good thing. My brain would be like, that's good. But if in the past I've seen my finger bleed when that happens, my brain goes, oh, we felt that before. We're going to interpret that as pain because there's something really serious going on. Yes, Miss Cooper.
I don't know. I think that a lot of the times you can, to an extent, control it with the way you think too.
Yes, you can.
That's
Yeah.
why people who get tattoos and stuff, like you're like, did it hurt? And they're like, it was intense.
Yeah.
It was intense because, like, I don't know, if you tell yourself that you have a high pain tolerance and try to change your mindset, it might actually help.
It does. There's no doubt. We know that for a fact. And I'm not suggesting you haven't felt pain when you felt pain, but we know for a fact that your interpretation, this is what the neuromatrix theory of pain means, that you interpret nerve signals, and that gives you your final experience of pain. And when you're getting ink done, you want to get it done. You're into it. So when somebody gets ink done that's into it, they're excited about it. And so they experience pain as intensity. Athletes do this too. People that aren't athletic at all, they go work out and they experience that sensation as my muscles are burning. This is awful. I hate this experience. Athletes feel the same thing, but they're like, it's intense. I like it.
Same
Right?
with getting piercings.
Yes. It's also the same thing with birthing a child. I'm not suggesting a child is not, I can't even imagine. I'm a guy. But it's better if you're excited and you're happy and this is your baby coming into the world, right? It changes
that's
your
why
interpretation.
people get trainers. Like,
Yeah.
sorry, that was,
Something?
sorry,
Sorry.
moving, but
Yeah. Anyway,
people get, like, coaches.
yes. So all this stuff, all I'm trying to say is exactly what Ms. Cooper is saying too. That the neuromatrix theory of pain says that you interpret signals coming into your brain and then you decide if they're painful or not and how painful they are. Why would this be important to massage therapists? Anybody? Ms. Cooper, you still have your hand up? Is that just because it's up? Okay. Miss Monreal.
I guess for us just to be mindful of where people are with their pain. Some people are more sensitive than others.
Mm-hmm. I agree with that, by the way. I also like to remember that some people, especially when they've never had massage before, sensations, they interpret some sensations as pain that aren't damaging. And I've had this happen 500 times. I'm maybe 5,000 times. I mean, a lot. Where somebody goes, oh, I'm like, is that painful or is that therapeutic? And they'll be like, oh, I never thought about that. I guess it's kind of therapeutic. And you'll even hear their voice change. And all of a sudden I'm like, oh, okay, well, can we continue? Yeah, you can. I've just helped them decide if something's painful or not. I'm not saying I talked them out of it. I'm saying they were like, oh my God, that's new, and it must be pain. And I'm just like, is it pain or is it therapeutic? No, I guess it's just intense, it's therapeutic. So that's one of the reasons that we do this. Make sure that you're really finding out what your client's experiencing. I also love, this is my favorite question to ask, when somebody says something hurts. My favorite question, this is like right up there with do you want more or less pressure? My next favorite question is when somebody says that hurts, is that a good or a bad pain? I'm asking that because they're better off at telling what's going on in their body than anybody else. And if it's a good pain, they might want me to continue. I've backed off on people before, but they're like, well, don't stop. Yeah, it hurts, but it's therapeutic. Oh, okay. So that's a good pain. Or it's a bad pain, I need to back off right away. Miss Monreal.
Okay, I wasn't confused by your comment, but I just want to clarify. Okay, so you say, is that pain or is that therapeutic? So what are you necessarily meaning by therapeutic in that statement?
Thank you.
I would assume that both are pain, you're just trying to classify it, correct?
Yeah, I'm trying to classify it. I'm also trying to get them to think about it a different way because there is good and bad pain, right? So, so have you ever flossed your teeth and it kind of hurts a little bit, but it also feels like you're getting the food out of there? It kind of hurts, but it kind of feels therapeutic, and you're kind of like, I kind of like it,
Okay.
but it kind of hurts, but I kind of like it because I can,
Mhm.
you know, that is a therapeutic pain. I mean, it's just, or a stretch. When you're stretching, you're like, oh man, I really feel a burn here. Stretching's kind of painful sometimes, but it feels really therapeutic. And I'm trying to get them to make a decision about that too, because some people just interpret everything as pain. Right?
Okay.
And it's not. And sometimes just me asking that question, they all of a sudden switch to, oh yeah, it's kind of therapeutic. I guess that's kind of, yeah. So do you want me to stop? No, I guess not. It kind of helps them work through that interpretation in their head.
And kind
Right.
of make the decision themselves
Yes.
instead of
Yes.
feeling like you're pushing something on them.
Yes. And you
they're
don't
not
want to do that.
comfortable with.
That'll burn you every time. Yes. And the other thing is just ask if somebody says something hurts. Please, everybody remember, if somebody says something hurts, ask them, is this a good or a bad pain? Good pain probably means you should continue doing it. Bad pain probably means you should stop. But ask them.
Okay.
If somebody says, does this hurts? Ask them, is this a good or a bad pain? Yeah? Miss Moore, if somebody says, this hurts, what should you ask them?
Would you like more or less pressure?
Ha! Good answer, the wrong answer, but a great answer because I love hearing that. And actually it would work. Do you want more or less pressure? I like that. But you should ask them if it's a good or bad pain. Yeah. But I actually do like the save all answer there. So thank you. Thank you. Cool, cool, cool. All right. Moving right along. So have you guys ever heard the term neuroplasticity? It should sound like nerves and plastic, and those are what the root words are from. Neuroplasticity just means that your brain can actually change. That the neurons in your brain actually change and remodel, and you can learn new patterns of thinking. So we all have some PTSD about something. Past relationships, certain things that just kind of trigger us and stuff like that. And some of the stuff we kind of learn to do through life is to reprogram that stuff so it doesn't trigger us every time. And that's neuroplasticity, that we can actually change stuff. It's why I ask people, is it painful or is it therapeutic? Believe it or not, in that moment when they say, oh, it's kind of therapeutic, I am using some of their neuroplasticity to change how they interpret certain types of pressure. They've never had anybody put an elbow in their low back before. They don't know if that's painful or therapeutic. And they make that interpretation. So your brain is not fixed. Your neural pathways are not fixed at any age, by the way. You can learn stuff differently. You can learn to interpret differently. You can learn to love differently. You know, we all have certain patterns built in. So, another term you should know is what's called neuropathic pain. Neuropathic pain is not, it's not usually generated by a nociceptor, which means there's not usually actual tissue damage. Lots of you have neuropathic pain. You know where your neck's kind of hurting sometimes? That's usually a pinched nerve in your neck. That's very typical neuropathic pain. That's when a muscle is often pinching down on the wire. So right, it can even, like a nociceptor's at the end of the wire, right? It tells tissue damage, but if you pinch down on the wire in the middle, that sends pain signals back there. Well, those aren't real tissue damage, right? So neuropathic pain is not being generated by a true nociceptor being set off. Yeah? Cool, cool, cool. And then there's chronic pain. You will hear about this all the time. Chronic pain. These are just some definitions you should know. Chronic pain. Anybody tell me what chronic pain is?
I forgot to put my hand up. Does anyone else want to answer?
Yes, they all did. I'm teasing. I was hoping somebody else would jump in, not because I don't want to hear from you, ma'am. Miss Monreal, what is chronic pain? And thank you for answering.
Chronic would be not acute, which acute is I don't know how many days or whatever, but something that's there all the time, that's chronic.
Yes, something that's there all the time and lasts longer than it should. So you hurt your back, that's acute pain. Your back still hurts a year later, that's chronic pain. Yep, and you will have lots of clients come to you with chronic pain. Massage is actually one of the best things for chronic pain because they're like, we don't know what to fix this thing. It's really basically been repaired, but it's still hurting them. Chronic pain is something where it's a chronic problem. Chronic means it's persistent, it's ongoing, it outlasts the typical healing period. Yeah? Cool, cool, cool. Miss Felix Osuna, what's chronic pain?
It's pain outlasting typical healing in terms of both tissues.
Yeah, thank you. We'll take it. Let's talk really quickly about pain threshold and pain tolerance. Threshold is just the minimum amount of stimulus it takes to get you to actually experience something that's painful. For example, I can put a warm towel on your hand. You're not going to experience that as painful. I can put a hot towel on your hand. That might not be painful. And then I can put a really hot towel on your hand, and that's going to finally hit your pain threshold, and you'll experience it as painful. Pain tolerance is your ability to deal with pain. The maximum amount of pain you can deal with before you, well, usually before you pass out. Anyway, some people have higher pain tolerances than others. By the way, I don't mean, well, I think it's true. From my experience, women have higher pain tolerance than men, for example. Sometimes I get these big guys come into my massage and they actually didn't do as well as just some lady that walks in. But anyway, pain tolerance is your ability to tolerate pain. And some people have a very high pain tolerance. Some of the problems that we deal with in chronic pain stuff is what's called sensitization, which is when nociceptors actually get oversensitized and they go off easier. In some chronic situations, there's actually something constantly setting off the nociceptors. You think that would make them get less receptive, but in a sense they get hypersensitive, right? It'd be like if I picked on one of you in class all the time, besides Miss Monreal. She seems to thrive off of it. But if I picked on you all the time, you'd be hypersensitive. And so if I was constantly making fun of Miss Hanson and saying stuff about her all the time, and then I just go, hey, Miss Hanson, what's sensitization? She'd be like, what? She'd be overly sensitized because every time I call on her, it's something bad. And now I just asked her a question, it sets her off. That's sensitization. Okay, boom. Let's talk about trigger points. Every massage therapist talks about trigger points. Your book has a definition of trigger points. I want to caution everybody that trigger points are something that are still very little understood. And I feel very overemphasized. So, trigger points, oh, there's so many different definitions, but trigger points are usually defined, and your book doesn't even quite define them this way, but they are usually defined as a tender, tight spot in muscle or fascia. This is Tapscott definition, but it's also other people's. A tender, tight spot in muscle or fascia that has referred pain. So a trigger point is like, oh, it hurts here, and it's tight here, and it feels like there's a little knot there, but also when you push it, it might hurt here, but it also hurts down here. Trigger points tend to be pinching nerves too. And so referred pain used to be the thing that you had to find a knot that referred pain. You had to find a knot that referred pain to have a trigger point. Now, your book doesn't say that it always has to refer pain, but many people still say it's not a trigger point if it doesn't refer pain. If it's just tight there, it's just a knot. It's just a tight area. But anyway, I always think of it as a localized area that's tight, that probably hurts, although not always, and refers pain to somewhere else. And massage therapists believe that when they find those. They should press on them, which I'm not against. Press on them for 10 to 20 seconds and try to get them to release. How hard do you press on them? Good question. Not hard enough to get the client to start tensing up, but it's going to be painful. Yes, Miss Monreal.
I heard, which I never do because I'm not that patient, that you should press on them even up to 5 to 10 minutes to hold that pressure.
Yeah.
What do you think about that?
I actually, in a way, kind of agree with it. Not 5 to 10 minutes, but the 10 to 20 second thing to me is too short. I don't want to hold on to anything so long that tissue's not getting blood for a really long period of time. So after 2 minutes for something, I would let it go. But I've held on to stuff for a really long time before. Yeah. Because I think it gives the brain time to really shut off that area and the tissue to really stretch out. And I'm trying to create a stretch. And some of the best stretches are at least 20 seconds long and up to 2 minutes long. And so if I'm really trying to stretch out tissue and you can tolerate it and you're not tensing up, I'll go up to 2 minutes. I'm not a big trigger point fan, though. I'm not, because I feel like people treat them as though, oh, that's a trigger point, that's your problem, and if we fix this button here, everything's going to be better. I'm much more structural, and I'm like, okay, there's a sensitive spot there, let's rub it out, but let's look at this whole muscle here and why it's shortened and what's going on. I just feel like trigger points, sometimes therapists use them to be lazy, to be honest with you. They sit down, they go, okay, well, let's hold this trigger point. I'm like, let's get in there and rub some stuff out and open it up. So I'm not against trigger points, but I don't like entire trigger point massages. However, you will occasionally have clients that like them. And you essentially go around and you find these spots, and they're like, oh, that hurts right there. And you hold it, and 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 hold it, until you feel it release, or you get to about 2 minutes, and then I'd let it go. You will see some trigger points create this thing they call a local twitch response. This is important to remember for the test you're going to take today. It's not an important phrase to remember. That just means that when you hit the trigger point, it's a trigger point because it's trapping a nerve, and so sometimes you'll get a little twitch in there because you've hit a nerve. I mean, kind of how nerves work. You'll also hear people talk about active trigger points and latent trigger points, and it doesn't matter. You treat them the same. Active ones are the ones that clients are aware of. Latent ones are ones that they're like, oh yeah, it hurts, but I wasn't aware of it. That's it. I don't mean to sound so frustrated, but I feel like they make names for stuff that just is a spot that hurts. So active trigger points are a trigger point where the client is like, oh yeah, that's been bothering me for a while. Latent ones are ones where they're like, oh, that hurts, but I wasn't aware I had it. Okay, well, we're still going to work on it. So we believe, and we are not sure, that one of the problems with trigger points and how they're caused ties into how muscles work. So, do you remember that when you had a nerve coming down to tell a muscle fiber to fire, that nerve released a chemical to tell the muscle fiber to fire? Anybody remember that? That was a neuromessenger, a chemical messenger, and it would send this whole thing, the muscle fiber would be like, okay, and it would contract. Does anybody remember what the neurotransmitter was, that chemical that makes the nerve, the muscle fire? It's in this slide. It is going across the synapses, yes, Miss Stanley. But what's the chemical messenger going across there? Miss Monreal? Yes. Wait, I got
Is it acetylcholine?
Yes, it's acetylcholine. That is the neurotransmitter. Well, what we think happens is, let's just take stress. I'm sitting like this right now, and I'm stressed, so I got my shoulders up like this, right? I'm telling myself to raise my shoulders unconsciously. Well, that means my brain has to send a signal down my neurotransmitter, my nerve, and send out acetylcholine to tell my thing to contract. And then you start to get excessive acetylcholine in an area if it's doing it all the time. And if that excessive acetylcholine builds up in a little area, we think it keeps it in a contraction and keeps it locked. We're not sure, by the way. Your book talks about it as though we're sure. We're not sure. But we think excessive acetylcholine kind of keeps that little area, that portion of that muscle in a contraction. That's all. Oh, and by the way, I should say this. Once it's contracted, blood doesn't get into it very well. The problem with trigger points, knots, whatever you want to call them, is that once something contracts, blood doesn't get into it very well, which is the thing it needs to wash out the acetylcholine, get new nutrients in there and loosen up. So you come along and you try to press on it and open it up so blood gets back in there and washes it out, and now it stays loose. That's the whole concept. It's a circulation game. Because like this, I do not get as much blood into my shoulders right now because they're always contracted. If I'm opening and closing them constantly, that gets blood into them. This is great. Do this all day long. That's fine. But holding them in one area contracted does not. Does that make sense? Yes, Miss Monreal.
What about lactic acid? You hear people say that all the time. So what's up with that?
So same concept. Lactic acid is a byproduct of your muscles firing. It's a waste product. And it gets flushed out with your bloodstream. But if a muscle is always in contraction, blood can't get in there as well to get the lactic acid out, and the lactic acid stays built up. And some people think that can lead to trigger points too, or lead to knots. And I don't know if that's true or not. I'm not arguing that it is. It makes sense to me, but both are solved by the same thing, which is getting blood back in the area. I do think that all these things are related in the sense that blood flow is reduced to the area because there's a tension spot there. And the tension spot's keeping blood out, and the blood not getting in is keeping the tension spot. And so the whole thing is a circulation game. Yeah. And I do think there's lactic acid that builds up in muscles, by the way. There's no doubt about it. One of the things we do in sports massage is just try to flush people out so we get lactic acid out of their body. Increase the circulation, get lactic acid out of their body, and they repair faster. Yeah. It's my favorite word here on this slide. Fascia, fascia, fascia. You have nerves in fascia, so you can have problems with fascia too, sending pain signals to people's bodies. You can get layers. Remember, fascia is just sheet-like connective tissue, right? Really everything's fascia. But my skin can actually get stuck to lower layers of skin, and the nerves are in that stuff, and that hurts just in and of itself. So just lifting up my skin and releasing it from the skin underneath can release that pain. So fascia can be a source of pain. Most definitely, quite often it's a source of pain. And you've got fascia in all sorts of layers in your body, so that fascia can get stuck in areas. That fascia can be tight, and you just loosen up the fascia, gets the nerves to kind of unstick, and everything's better. So don't underestimate fascia. It's not all about muscles. It's about muscles and fascia. There is a term you should know, and there's a term you should use. Let's talk about fascia for a second. Fascia is made up of 3 elements. Listen up. Fascia is made out of 3 elements. It's made out of collagen, elastin, and something called ground substance. Collagen, elastin, ground substance. Miss Cooper, what's fascia made out of?
Collagen, elastin, and ground. Did you say substance?
Yeah, and you nailed it. Thank you. Thank you. Thank you. Thank you, thank you, thank you. Mr. Kandaris, what is fascia made out of?
Sheets of fibrous tissue.
Hold that thought, sir. Miss Cooper, can you tell us again what fascia is made out of?
Collagen, elastin, and ground substance. What exactly is that?
I'm going to explain in 1 second, but I'm just making sure people are listening. So what's it made out of, sir?
Collagen, elastin.
Yeah. And ground substance.
Ground. Yeah.
Cool. Ms. Torres, what is fascia made out of?
Ground substance,
Yeah.
elastin and collagen.
Yeah, thank you, ma'am. You probably know that as an esthetician. Ms. Hunter, what is fascia made out of?
Ground substance, collagen, and elastin.
Thank you, ma'am. And Ms. Harper, what is fascia made out of?
It's made out of collagen, elastin, and ground substance.
Okay. Now let me tell you what that stuff is. Fascia is fascinating stuff. It's fascinating. Fascia has this ability called thixotropy, or thixotropy. And it means that it can be very solid or very gel-like, depending on what you need it to be like. And here's why it can do that stuff. Fascia is essentially a gel-like substance, kind of like Jell-O. That's the ground substance. So think of Jell-O. When Jell-O's cold, it's fairly firm. When it gets warm, it actually turns to liquid, right? That's ground substance. Then this fascia, this Jell-O, this ground substance, has two different types of fibers in it. Literally fibers running through it. One is elastin, which is like little rubber bands. I really mean that, little rubber bands. So you put elastin in it, and now this Jell-O can stretch out and come back together. Stretch out, come back together. In fact, what our younger students have in their fascia that I don't have as much of in mine is elastin. It's a reason their skin stays taut and plumps back together. It's a reason that mine has more wrinkles. It doesn't, that's right, Miss Cooper. It's a reason you're so beautiful. Elastin, right? It lets your skin bounce back. It's one of the things we test for in a client. If their skin doesn't bounce back a lot, don't go as deep on the massage. Yes, Miss Cooper.
It's also a good skincare routine and sunscreen.
Yeah, there you go. Bam! None of which I do, so good point. So, elastin is literally like rubber bands in the Jell-O. The Jell-O's ground substance, elastin is rubber bands, and then there are tiny steel wires called collagen in there, and they act like rebar in there. And the steel wires keep the Jell-O from tearing. The elastin helps it pull back together, the steel wires keep it from tearing, and by the way, when I say steel wires, collagen is pound for pound stronger than steel. Now these wires are tinier than hairs, but pound for pound stronger than steel. So ground substances like Jell-O, elastin's rubber bands in the Jell-O, collagen is little steel wires in the Jell-O, and you now have a substance that is elastic, comes back to shape, can't be torn because it's got steel in it, and when it gets warmer, because of thixotropy, when it gets warmer, it gets more gel-like and more malleable, and when it's colder, it gets more firm. Miss Monreal, do you have a question?
Well, I didn't realize that my hand was up, but
Oh, God.
you called me.
But you got a default question, yeah.
So if it gets more malleable when it's warmer, would it be safe to say that if we increase the blood flow or are moving our muscles, then that makes the fascia like soften up?
Yes, that was going to be my next question, yeah, is
Oh.
why do we care? And you answered it. You preemptively answered my question, which is we care as massage therapists because that's why we warm up tissue. Massage therapists are always like, I'm warming up the muscle. No, you're not. You're warming up the fascia, which happens to surround the muscle. The muscle's probably warm already, essentially. The muscle doesn't need to be warmed up. It's the fascia that needs to be warmed up. Anybody here done Bikram yoga? Anybody heard of Bikram yoga? Anybody
I've
tell?
heard of it, but I've never done it.
Can anybody tell us what Bikram yoga is?
It's that guy on the Muppets, Bikram. No.
Miss Petrie, I feel like you're about to tell us. Were you about to tell us, Miss Petrie, or no?
Is it a type of hot yoga?
It's yoga in a hot-ass room. That's what Bikram yoga is. And a hot, I honestly mean like 95.
Like it is hot.
Like I did it once. And anyway, you stretch really well. You are, and you are, by the way, people bring in beach towels. You are sweating buckets. I mean, buckets. I've never sweat like this before in my life. It's 95 degrees, and yes, Miss Giannis, it's disgusting. Everybody's sweating buckets. So you're sweating buckets, but I'm not a terribly limber person, and I was able to touch my toes in that class because because of thixotropy, your fascia gets so warmed up, it's so warm in there, and they're stretching you, which makes it even warmer, and you're able to stretch further. It's very, very effective. I only did it once because I felt wiped out for like a week afterwards, and people are like, oh, that's the toxins leaving your body, and I'm like, either that or heat stroke, because honestly, I'm not really sure it's good for you, and I'm not sure. That's my bias, by the way. Some people swear by it and they love it, and I totally get it. But for me, I'm just like, I don't think it's healthy to sit there and go to that extreme. But that's why it works, though, because of thixotropy. Works because of thixotropy, because the Jello with the collagen and elastin in it gets soft, and you can stretch further. Yes, Miss Cooper.
I just never understood how to breathe when they do all of the breathing techniques in that hot room. I'm like, how am I supposed to do this?
I just felt bad for everybody around me because even with the towel there too, I'm kind of run hot already, and I was just like, this is crazy. Anyway, yes, Miss Cooper.
Doesn't sweating a lot also help you lose weight? Is that a thing?
Yes. By the way, two things, yes and no. So, sweating helps you lose weight instantly. The problem is it's water weight. And the minute you drink water again, you're going to gain it back, and you need to drink water again. It's not healthy to lose water weight. So, sometimes bodybuilders, by the way, do this. I'm just using them as an example. It's a great example. Bodybuilders not only lose all this fat, right, all this adipose tissue so you can see their muscles, but they will take diuretics the day before competition. Diuretics get water out of their body. Well, that's all fine and dandy, but people have died from it before on stage because you need water. You need water to make your muscles fire. And what's the most important muscle in your body? Anybody?
Is that a good question?
It's a real question. What's the most important muscle in your body?
I feel
Yes.
big.
Yes, Miss Giannis. Your heart.
Okay.
It's a four-chambered muscle, and on diuretics, it sometimes doesn't have enough water to keep firing, and when your heart stops...
That's crazy.
Yeah. By the way, this is the other reason, just a side note, that you're supposed to take water with you when you're hiking. So there's been a lot of cases where people hike down into a canyon, they run out of water, and they're like, well, I've just got to hike back up, but they don't have enough water in their body, and your muscles, this is not an exaggeration, your muscles, when they're dehydrated, lose about 80% of their power. So when I hike down the canyon, to my legs now that I'm dehydrated, it feels like I weigh 700 pounds and I have to hike back out. Think about that for a second. This is why
That's
people
why they try to tell people not to hike in the summertime.
Yeah.
Because nobody takes enough water with them,
Right.
and then they have to be evacuated out because they're almost dead.
Yeah, and what people don't realize is they think, well, I'm not going to get that thirsty. That's fine. That's not the problem. You can live without the water for quite a while, but what you don't realize is you lose 80% of your power and you can't get back out. And then you die, right? So your muscles, when they're dehydrated, lose tremendous amounts of power. Tremendous. You're a child. You've lost 80% of the power of your body. Anyway, thixotropy means the ability to heat up fascia and have it become more gel-like and more malleable. Yes, Miss Monreal.
You don't have to talk about this now, but since you were talking about stretching, I know that sometimes when people are stretching somebody else, they kind of like have a little bit of a bounce to the stretch, but then I heard that that's wrong.
Yeah, I have and again, I mean, we're still learning a lot about the human body, but yes, everything I've ever read says do not bounce when you stretch. And here's why. One thing is you can injure yourself, but the other thing is You have stretch receptors that we're going to be talking about today, actually. And stretch receptors, when you bounce, they tend to go off and they tend to try to stop your stretch because your body senses you might be going too far. It's a lot more effective if you ease into your stretch receptor so you don't set it off. Because if you set it off, your brain literally goes, this doesn't feel right. I'm going to stop this stretching process. And you want to keep the stretching process going. Same thing's true with pressure, right, Miss Monreal? I can gently put my elbow into your back and then eventually lean all the way in, I bet. And you'll be okay. But if I throw it into your back, you're going to react very differently. Cool, cool, cool. All right. Okay, so we're going to talk next about assessments, but I feel like we need a little break. I don't know why. Not because people are maxed out, I can tell, but let's just take a 10-minute break. I just feel like we skipped around a lot about a lot of stuff, and I want to kind of center in on assessment. So let's take a 10-minute break. See you guys back here soon. Let me stop sharing here too. Let's stop presenting for a second. Run through some stuff with you guys. All right. So, wow, I gotta really put this thing lower to make this work, huh? Wish it didn't have that option. All right. Good. Okay. All right. So, if I have a lateral tilt of the hip, I'll often be messed up and not aligned in the sagittal plane. You'd like me to be evenly split side to side in the sagittal plane. But if I get a lateral tilt to the hip, it'll often throw me off laterally, one side or the other. So it lets you know there's problems possibly on the sides of their body. Yeah. What if we take that same plumb line and put it down like this and divide the person front to back? What's that plane called if it comes to the side here? Divided me from frontal plane. Thank you very much, Ms. Torres. Frontal plane comes through here. By the way, we're supposed to run the line down through my ear, through my acromion process, through my greater trochanter, and just in front of my lateral malleolus, just in front of the bump on my leg. If you see the person kind of standing like this, or coming in and out of that plane too much, these things would tell you there are problems in front and in back of them, correct? Does that make sense? Right? You'll see some compensations I am making as you put a plumb line down here. What I'm doing is to offset my belly a little bit. I'm leaning back a little bit. I'm exaggerating right now, but you'll see some of this. So the frontal plane's coming through too far in front of my head and then behind me, so I'm doing this kind of thing. So we can look at that kind of stuff to see how somebody is compensating. Yeah? We also use transverse plane that goes through like this to look for things like this. Right? One shoulder is above this transverse plane, the other one's below this transverse plane. That's not good. What muscle is probably tight right here? Anybody?
Would it be rhomboids?
That would be more like this, probably.
Oh, okay. So elevating would be scapula.
Scapula's not a muscle. But the scapula, is elevated. What? Who said traps? Trapezius. Is it unilateral or bilateral?
Unilateral? Is it?
Yes. Unilateral.
Is it an elevator scapula?
Levator scapula could be too. Unilateral though, right? Just on this side. This side's fine. This is a real problem. You'll sometimes see this, by the way, when people have tilted hips. Because this hip comes up, guess what my body has to do? It has to do this to offset. So I'm elevated here, but I'm elevated because there's actually a problem with my hip over here. This is how I'm compensating. Yeah? So we will often look at people and how they stand in certain planes to get an idea how to work on them. Now, do I have most clients come in and say, hey, stand over there, let me kind of assess you? No. But I can tell a lot just by somebody walking in, right? If they come in and they're kind of like this, I'm already like, what's going on with that in my head? I don't say that to them, right? If I see somebody kind of standing way and kind of leaning a little bit over, I start to think about pelvic tilt. If I see somebody kind of doing this thing, I'm thinking about lateral tilt of the pelvis. So you can tell a lot by just looking at somebody and how they're standing. One of the things I really look for is head forward stuff, because that throws everything off. If that head's forward, then the low back's really holding a lot of weight, the neck's really holding a lot of weight, and I want to get this back like that for sure. So that's obvious stuff that you can just tell when you're looking at a client. But what you are doing, whether you know it or not, is you're assessing them with the mid-sagittal plane to see if they're standing, not leaning towards one side or the other, or parts of their body aren't going off to one side or the other. And then you're looking at them from the frontal plane to see if they're leaning forward or back in certain areas, or just their butt sticking out, or just their back sticking, whatever. You're looking at that kind of stuff. And you're looking at transverse plane to see, are their shoulders even and are their hips even? Or are there lateral tilts in them? That's the most common stuff you're looking for. Especially in their hips, because everything else is stacked up on top of them. Yes, Miss Monreal.
So if their head is forward like you just showed, what would that be?
Uncomfortable?
I mean, because oh, yuck. Okay.
What would be the cause of that?
Well, yeah, I mean, I'm assuming your body's always trying to equilibrate, but what muscles would you target that?
All right. Let's talk about it for a second. I'm going to pin myself back here so I can see. This is the most common cause. This is not the only cause. Who knows? Hold on. Grab a chair here. All right. Okay. This is me grading your papers. Grading Miss Monreal's paper. Oh my gosh. I do a lot of this. I'm kind of stressed out. A lot of this. I do this for 40 years. Now when I get up, what's the stuff that's shortened? What's the stuff that could be creating this?
So as from sitting there?
Yeah, that was a great one, by the way. Iliopsoas right here. Hip flexors, right? What are some of my other hip flexors besides iliopsoas? You're right about that, by the way. That's huge.
Okay, and then what about the neck muscles from looking down?
Right, so there's going to be a lot of shortening back here, right? And I'm kind of tight here. And there will be lots and lots of holding back here, just trying to hold my head up.
Okay.
So we're going to, one thing is, you can loosen this stuff up. That'll help make them feel better. But until we stretch this out, and we actually stretch this out by pushing my hip in, you're never going to make it better.
Okay.
So that is a great example of how the neck is something you'd work on, right? But it's actually the iliopsoas and the hip flexors that you'd correct.
Okay.
Right? So it leads to my next question that I'm going to be asking you guys, which is to name all the flexors of the hip, which we've talked about many times. Does anybody want to take a stab at it and save your classmates so they can at least hear somebody else say it once before I randomly start calling on people? Because it's really important. These are the things, for one thing, what is a flexion of the hip? It's when I'm bending forward or lifting my leg up, right? It's this coming together thing. That's a flexion of the hip. So what muscles are hip flexors that we've learned about so far? Because we've learned about, I think, all of them. Yeah. Anybody want to? I see, Miss Petrie, you have your hand up.
I will.
Oh, Miss Torres. Okay, you're
But
feeling.
I don't know, but you're gonna help me.
You're feeling bold. All right, Miss Torres, let's do it. What are the flexors of the hip?
Okay,
Hold on.
so it's gonna be your iliopsoas.
Your iliopsoas is number one. Iliopsoas is number one. It's the thing that's inside your body, right? I was thinking about if I should. Here, hold on a second. Before you go further, just hold on. All right. Okay. Let's tape some of these off. Okay. Just so we have a rough idea what we're talking about. Can we see? Yeah, we can. There we go. Boom. Good. Okay. All right. So you said iliopsoas, which is two muscles, psoas major and iliacus, that essentially do this, and they can cause you to flex down here. Yes. What's next? Give me something else.
Sartorius?
Sartorius, which actually hooks up here and goes down here. Yes.
The TFL?
Oh my God, that was a good one. Yeah, TFL, which is really just up here, but it ties into your IT band. And so it kind of runs down here. Yeah. Nicely done.
Your gluteus minimus?
Yes. Some people would argue
Minimus,
medius too, but we'll definitely take gluteus minimus, which is kind of off here to the side. Definitely a hip flexor. Good.
And your rectus femoris?
And your rectus femoris. Beautiful. Which actually goes all the way across your knee, down here. But the important part is it also hooks into your hip.
And some adductors?
So and you could argue some of the adductors, sure. If they're really in front, like the pectineus could actually come down in here. Things like that. Sure. We'll take that.
I don't remember anymore.
I don't remember anymore either, Miss Torres. That means you did a really good job. All right. Let's see who I can't see right now. Miss Hunter. Miss Hunter, what are the muscles that are responsible for hip flexion?
The muscles?
Yeah.
Okay. Is it everything she just said right there?
Yes.
Or is it different?
No, I'm asking the exact same question.
Okay, I just want to make sure.
Yeah, no, it's okay.
Sartorius?
Sartorius, yes.
Iliopsoas,
Yes.
TFL,
Yes.
I don't know the other one, if there is another one.
Is there a quad muscle?
Yes. Rectus femoris?
Yes. Let's see. Sartorius, rectus femoris, TFL. Is there a gluteal muscle?
Gluteus minimus?
Yep, we'll take it. We'll stop right there. Thank you, ma'am.
Yay!
Yeah, that was good. It was really good. Yeah. Let's see who else. Oh, can't I see? Miss Nguyen.
Yes.
Hi, Miss Nguyen. Which muscles can create a flexion of the hip? Which means they can also create an anterior tilt to the hip. Quadratus what? What? So, Miss Nguyen, which muscles can create a flexion of, these are flexions too, and this anterior tilt flexion of the hip? Which muscles in front here can create a flexion of the hip? It's the same question I asked the last two people. Yes, rectus femoris. Yes, good.
Medium? No.
Yeah, and gluteus minimus. Let's go minimus for sure. Gluteus medius, there are some fibers, I admit, but minimus for sure, yeah?
And one more.
3 more. Let's go.
More.
What's this muscle way up inside here that goes from your lower back into your hip down inside your leg? We haven't studied it yet, but we've been talking about it a lot.
What is that? What is that?
No, iliopsoas? Can you say iliopsoas? Ilio?
Audio.
Psoas.
Sure. Yeah.
Okay. What about a diagonal muscle that runs across here? It's all by itself. It's not in a group. It's a diagonal muscle that runs across the leg. Starts with an S. Starts with an S. SAR.
Please tell me so I.
SAR.
Sar.
TOR.
Tor.
E.
E.
Us. Sartorius.
Tor.
SAR.
Tar.
TOR.
Tor.
E.
E.
Us.
Sartorius.
Sartorius, yeah. And then there's another really tricky one, kind of on the side here, called the tensor
Tor.
fascia
Fascia.
lata.
Lad.
Good. Tensor fascia lata.
I
And,
can hear you actually do that rule.
and Miss Torres even pointed out like the pectineus, which is a pretty good little guess in there too, like one of the adductors. You could argue that too. All right, thank you, Miss Nguyen.
Mr. Touchstop,
Yeah,
can you say the TFI one again?
the TFL one.
Yeah.
Tensor.
Tensor?
Tensor. Fascia lata. That's the way I was told to pronounce it. I've heard some people say it. I've heard everybody says tensor, but some people say tensor fascia latte. Let me see how the thing. Hold on. Tensor. Yeah. Here we go. All right. Hold on.
How do you pronounce
Say it.
tensor fascia latte muscle?
Tensor fascia latte. I say tensor fascia lata, but tensor fascia latte. It tenses a lot of fascia. That's what it does. The IT band is a lot of fascia. It tenses a lot of fascia. That's what it does. It's kind of cool. Tensor fascia lata. TFL. Yeah. Good question. Good. Okay. Miss Felix Osuna.
Yes.
What are the 5 or so muscles that are hip flexors?
For them, it's like the.
What?
Sorry.
That's okay.
So is major.
Psoas major, yes, which is up here.
And then sartorius.
If you're going to mention the sartorius is 100% correct, but if you're going to mention the psoas major, you might as well also mention the iliacus, which is what we call the iliopsoas. Anyway, sartorius then too. Good.
The TFL.
TFL. How do you say TFL?
I don't know.
Tensor.
Tensor.
Fascia.
Fascia.
Latte.
Okay. Tensor fascia latte.
It tenses a lot of fascia. Anyway, what's next?
I'm
TFL.
sorry.
What's the quad muscle?
So it's the iliacus, this was major, sartorius.
What's the
and
quad muscle that crosses over
The
there?
quad muscle?
Yeah.
The, is it the rectus femoris.
Yeah, it's the only one that crosses over the hip. Good job. Thank you.
Thank you.
Thank you, thank
Sorry.
you, thank you. Don't be sorry. You're fine. Miss Moore, what are the 5 muscles that can cause hip flexion?
The sartorius,
Yeah, that's one.
the tendus fasciolata,
Yeah, it's 2. Good.
the psoas,
Sure, psoas major. Which goes along with what other muscle? Psoas major goes along with another muscle. So often that we call
iliocostello, something.
the oh gosh,
I'm trying to think.
no, hold on.
Iliocostello.
The iliacus goes along with the psoas major, so much so that we call it the iliopsoas.
Okay, how many I got?
Iliopsoas. You said tensor fasciolata, iliopsoas, sartorius. Can you tell me a quad muscle that crosses over the hip?
No.
It's not the vastus medialis. It's not the vastus lateralis. And it's not the vastus intermedius. So what's the last quad muscle? Miss Moore?
Here.
What is the final quad muscle, Miss Moore?
I don't remember.
What are your 4 quad muscles?
Wait, can you say it again? Because I.
Yeah, what are the 4 quadriceps femoris muscles?
Medialis, the peroneus, the.
No, those are adductor muscles. The 4 quad muscles, there's 3 with the word vastus in them. All right, Miss Moore, I'm going to pass over you, but you need to be in a place where you can pay attention, okay? So pay attention to driving right now, but we need to correct this so that you can pay attention to class, okay? I'll come back to you. Thank you. Okay. Let's see. Miss Bilotic, what are like 5 or so muscles that can cause hip flexion?
Sorry, I'm trying to look at the blue tape.
I know, and in blue tape it's not super helpful, but
It's okay.
I can give you I can talk to you about certain ones if that helps.
Could you point
Yeah.
them out for me?
So I really care about one that's inside the body. It hooks from the lower back. It's 2 muscles, but we call it by one name. Hooks to the lower back, inside the hip, and actually goes down to the lesser trochanter. It's 2 muscles, but we call it.
Psoas major?
Psoas major is this one, and there's one in here. It's called the iliacus, and together we call them the what? Just take iliacus and kind of put it with psoas.
Iliacus psoas?
Yeah. How about iliopsoas?
Iliopsoas.
Cool.
Okay.
You guys will hear about this one all the time. Iliopsoas, cool. All right. What's the diagonal one that goes across your leg? People call it the Taylor's muscle because it actually lets me do this. Starts with an S.
The sartorius?
Yes. Awesome. What's the quad muscle? There's only one quad muscle that crosses over your hip.
Is that the rectus femoris?
All day long. Excellent, ma'am. What is the muscle that tenses up lots of fascia here? And hooks into
On
the
the
IT
side?
band. What?
On the side of the leg?
Yeah, it's a we haven't actually learned about it yet, but we've been talking about it, but we haven't had a slide thing on it yet. It's a tiny muscle up here, but it hooks into your IT band, and it literally the name means that it tenses up lots of fascia.
Is that long piece of fascia?
Yes, well, there's a long piece of fascia here. That's your IT band, and this muscle is up here at the top, and it's called the tensor something something. And it
Tensor fascia latae.
Thank you. All right. Then there's a gluteal muscle. Believe it or not, one of your glute muscles that actually can act as a hip flexor. Really 2, but one that's obvious.
Is it the
gluteus medius.
Gluteus medius, but even more in front than the gluteus medius is the what?
The gluteus maximus.
Maximus? Your Maximus is up here?
Oh wait, oh no. Sorry.
Makes for a funky looking person. I mean, I don't judge, but
So you said it's a gluteal muscle, right?
yeah. And there's only
Gluteus
three.
medius, gluteus maximus, and gluteus minimus.
Yes, minimus. Max is back here, med, and min. It's gluteus minimus.
Okay.
Thank you, ma'am. That was good. Mr. Kandaris.
Yeah.
Hip flexors. Tell me about the hip flexors, sir.
We got the TFL, tensor fasciae lata, and we got the rectus femoris.
Cool. Right.
What?
Yeah, cool. Tensor fasciae lata, rectus femoris,
Yeah, the sartorius,
sartorius,
the gluteus medius,
gluteus medius, and
gluteus minimus,
gluteus minimus. Thank you.
and then those are, or no, I already said that. The ilio,
Yeah.
psoas.
Iliopsoas. Good job. Thank you, sir. Thank you. Okay. That was a lot of stuff, everybody. I just want to kind of make sure we remember hip flexors. So that was a lot of stuff that pulls me forward, by the way. There's not as much stuff that pulls me back. So that's an easier question. So, Miss Giannis, what are my, she's like, I hate you. What are my hip extenders? By the way, they also let me do this. Like this is a hip extension, and believe it or not, this is a hip extension.
Your hamstring.
Yes, that's the answer I wanted. That is the answer all day long. What are your hamstrings?
Your bicep femoris. Your semimembranosus and semitendinosus.
Yeah. Now, you could argue that one of the adductors can kind of pull you back too, right? Which adductor is most posterior?
Your adductor magnus.
Yes. Great job, ma'am. Thank you. Miss Blodek, you have your hand raised?
I don't know if this is like a stupid question.
No.
But, I was just curious. So, if you're being pulled back by your hamstrings, would your glutes be any part of that as well, or not really?
Oh my gosh. Miss Blodek. Miss Blodek! You were worried about asking a stupid question. No! Instead, you have a stupid teacher. Miss Blodek. An extension of the leg is this, which is also my hips coming back. Do we all see that's the same thing, believe it or not? I'm not talking about my back coming back, but my hips coming back is the same thing as my leg going back. It's bending at the hip, right here. My hamstrings are the obvious answer. I asked for a more technical answer too from Ms. Giannis about my adductor in the inside kind of being in back so it pulls back too. And then one of our quietest students said, this might be a stupid question, but do any of the glutes get involved in this? Your gluteus maximus is your most powerful hip extender. Who forgot about the gluteus maximus and has two thumbs? This guy. Yeah, brilliant, Miss Blodek. Your gluteus maximus is in back. That's why it's maximus. It's back here. It's designed to do that. I'm not normally doing this. Normally what I'm doing is extending my hip. Boom. Yes. Oh my gosh, it's a great day. Bad day for me, great day for you. Thank you. That's a hip extender too. Wow. And this is why, by the way, I think gluteus maximus and hamstrings are very important with people with back problems, by the way. Because they're usually tight all the way down, trying to kind of get their back that way. Brilliant. So hamstrings, adductor magnus, and gluteus maximus. I think maybe you guys will have to start teaching the course, huh? Yeah. Cool. Thank you, ma'am. Miss Hunter, what are the extensors of the hip? We can't hear you, by the way.
Oh,
Okay, now we can.
okay. You said the 3 hamstrings, right?
3 hamstrings. What are their names?
Semimembranosus, semitendinosus, and bicep femoris.
Thank you, ma'am. And?
That's it.
And anything else that can extend the hip?
Extending, is it a gluteal muscle?
Yes, it's a gluteal muscle Miss Bolotic reminded us of.
Yeah.
Which was kind of funny because just earlier she thought it existed in front of her body, and then we all laughed, and then she was brilliant and explained that it was part of extending the hips.
Is it maximus?
Yes, ma'am, it's maximus, yeah. Could any adductors be hip extenders because they are so posterior?
Yes. Gracilis?
Which one is super posterior?
Is it the Magnus?
Yes, ma'am. Thank you. Perfect. Stop right there. You're good. Good job. Okay, everybody. Let's go back to our slide presentation. I just wanted to continue to tie stuff in, right, to postural analysis, because if you see somebody leaning a certain way, you'd have to work on stuff to fix that, right? Okay. So, let's get through this really quickly here. Let's see if we can. All right. Okay, here we go. So assessments are used to do what we just did right there. What's wrong with Tapscott? How's he standing? What muscles might be involved? What muscles might I stretch? What muscles might I massage? We saw that neck problems could often be lower back problems, could actually be iliopsoas problems. By iliopsoas are those 5 hip flexors or 6 hip flexors you guys identified. If you don't fix those, it doesn't matter. If I can't stand up straight, my neck's never going to be better. Ever. Ever, ever, ever. Right? Okay. Some people have what we call compensating patterns. Compensating patterns are when somebody does something to try to make up for another imbalance. So I actually showed you guys one. It was kind of embarrassing, but I said, hey, I've got a belly here. That's hard to carry, right? Like this. So what do? This is a compensating pattern. Get it over my midline. I'm exaggerating, but still, the point is this is a compensating pattern. I'm leaning back because I've got too much weight up front. Instead, I should be standing like this. By the way, just so you know, just so you're not frustrated if you can't help some clients, I would be greatly improved with massage, right? And you can help loosen up muscles that are bothering me, but until I drop the weight, the problem isn't going to go away. I mean, some of these problems are beyond you. You can't massage certain things away, right? Just to kind of keep that thing. But my postural muscles that cause me to do this, my extending muscles, and my erector spinae muscles that also extend my spine, they're all going to tend to shorten and strengthen. So you're going to find my back muscles are actually very strong, very tight, and very short. And somebody in this class worked on me. Was it? Who was it? One of you worked on me, and you remember my back, how it felt. Anyway, yes, Miss Stanley.
I worked on your back, silly.
That's right. And I was amazed how powerful you were, and you got your elbow right in there and stuff. It was tight though, right? That's a compensating pattern. Yeah. Yeah. That was a powerful little massage.
Thank you.
Thank you. Might have to try that again. Just to see how you're doing. Yeah. That's the only reason. Okay. ROM. Anybody know what ROM stands for? Yeah? See a nod? I see a nod. Miss Fleeks Osuda, what does ROM stand for?
Range of motion.
Range of motion. PROM stands for passive range of motion. I never hear people say that, but they just say passive ROM. But ROM stands for range of motion. What they mean is my arm should do certain things. My elbow should do certain things. My hips should do certain things. And passive range of motion is you moving a client for them passively and seeing what their range of motion is. We again do this in massage sometimes. Sometimes you'll bring people's arms out to their side and they stop right here and you're like, oh, this guy's chest is really tight because his arms really should be able to go all the way even past his body. Your arm should be able to do this. In fact, some people get it way back here. They should not be stopping here, but you'll see some guys with this that do a lot of bench press. Their arms are kind of, their pec muscles are kind of short. By the way, which pec muscles are short? If I can't get my arms back any further than this, which pec muscles are short? I love what Miss Giannis is doing. Even if she doesn't have the right answer, she's already doing the right thing. She's touching her pec muscle and she's trying to figure it out. Which pec muscle attaches from my chest over to my arm, not my scapula?
Oh, you're writing it out, Martin?
Miss Harper, yes.
Is that your back major?
Yes! Yeah, my pec minor moves my shoulders forward and back, right? Well, forward, not back. But my pec major hooks to my arm. So when my pec major is tight, my arm can't go back any further. Good job. Good job. Yeah. By the way, I think you're noticing I'm asking more and more questions about applied anatomy, right? What do we do with this information? Because that's where we're headed. You guys are doing really good. I sincerely mean that. This is where we get a little trickier. But it's kind of the more fun stuff. Like, who cares that it's called a pec major if you don't know what it does and I don't know when it's tight and I don't know what to do about it, right? Cool. All right. So I could take a client through passive range of motion and then find out that they can't go a certain distance, and I might determine, like, hey, I know what muscle causes this movement, this horizontal adduction. So if they can't do a horizontal abduction all the way, it must be that muscle is tight. Yes, Miss Petrie.
I just want to make sure I understand clearly that when the pec major is tight, you can't get full range of motion backwards. You can't do a full abduction. Is that correct?
Full horizontal abduction, yeah. I mean, it could be other things, by the way, but that would be the first ultimate culprit. And remember, it's everything that it's the opposite movement of what the muscle does. So the muscle adducts, and if it can't fully abduct, it's that muscle stopping you. What other muscle adducts my arms like this? It's not the main one. Pec major is the main one. But is there anything else that brings my arms together like this? Anybody? Horizontal adduction. Push your arms together really hard. See if you feel anything else going on. Miss Monreal.
Is it the anterior fibers of the deltoid?
That's a great answer. So the anterior fibers of the deltoid, which we think of as doing a flexion of the arm, and they do, but they can also aid in a horizontal adduction. Yes, 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 absolutely. Yeah. Is there a tricky little muscle we hardly ever talk about that could also be involved? That goes from the brachial region to the coracoid process of the scapula?
Coracoid.
That's the
coracobrachialis.
Coracobrachialis. It's a tiny muscle that goes from your coracoid process to your arm, and it helps with horizontal adduction for sure, and flexion. Good job. So those are the things I would rub and stretch out, and rub and stretch out at the same time, because that's very effective. Put something in a stretch and then rub. It's very effective. You got to be careful because it's sensitive, but man, does it work. Put them in a stretch and then start working their pec. You will open them up. Yeah. Very effective. That's my favorite way to create structural change in the body, is put something in a stretch and massage them at the same time. Anyway, that's just a really quick thing. Miss Petrie, you still have your hand raised. Is that just because? Okay, cool. I just want to make sure I wasn't ignoring you. So what when this movement stops, any movement, we're still talking about this one. So when this movement stops, that it's at its end. And you will hear therapists talk about end feel. End feel means the way the ending felt. So most end feel feels a little springy. Even if my pecs are tight, it feels springy because my pecs are stopping it, soft tissue is stopping it, fascia is stopping it, and so you get this springy end feel. That's correct. Some things actually have a bony end feel. When my arm stops coming out all the way here, it's not because the muscle's stopping it, it's because literally the bone here, my ulna, is running in to my humerus. This is bony end feel, if you can straighten your arm all the way. If my arm came to here, It'd be springy end feel. That's bony end feel. Yes, Miss Stanley, you're definitely having bony end feel because you're almost hyperextending there. But you feel it. It does not feel great, actually. It's two bones are hitting each other. That's bony end feel. Anyway, we feel for end feel on stuff. If you've gotten a bony end feel, that's as far back as they can go. Like, you can't move my arm any more than this. There's bone on bone. Don't try to stretch it further. No, it's good. No, all right? But if there's springy bone, if there's springy end feel, it means you can go further. So, PROM is passive range of motion. That's where you're moving the client's arm. There are times where the client is actively working with you. These are active ranges of motion. When we say active or passive, we're talking about the client, right? The therapist is always working, by the way. You are never passive, you're always active. Don't get confused with that. We're talking about the client. The therapist is always working. So you're working to move the client's arm around with or without their help. It's passive when you're just moving the person and they're just being like your kids sometimes when you pick them up and they're like, and they feel like they weigh 9,000 pounds. That they're being passive, you are actively carrying around. But anyway, that's passive range of motion. Active range of motion, you're still moving the client, but they're doing something too. They're either actively helping you or actively fighting you. Active assisted or active resisted. Active assisted is I'm lifting their arm and they're helping me lift their arm. Active resisted is I'm lifting their arm and they're pulling against me and trying to pull it away. Who cares? We care. Because this is the beginning of PNF stretching. Anybody know what PNF stands for? It's a big, long word. Ms. Monreal, you want to take a stab at it?
I'm totally taking a stab at it.
I like it.
Well, I think the first word isn't it like peripheral, neuromuscular, I don't know. Never mind. By your face, thanks. Nah, I don't know.
Neuromuscular is correct.
What's the, I don't know, what's the P word then?
Proprioreceptive.
Oh, I was way off. What the
Not really.
Okay.
I mean, you are proprioreceptive of your peripheral nervous system.
No. Don't try to fix it. It's all good. I was wrong.
I feel bad. I know what it feels like to be wrong. I've been wrong all day long.
You know. A lot today.
Anybody know what your proprioreceptors are?
I do.
Yes. What are they, Miss Monreal?
Those little things that let you know, like, the proximity you are to other things.
Yeah. So remember I said at the end of your nerve things, you have things like nociceptors that sense pain, but I said not all the endings are like that. They've got other stuff on them. Proprioreceptors sense pressure and bend and speed, and they're literally the reason I got my eyes closed like this, I can move my arm around and actually know where it is. We kind of take that for granted, but those are proprioreceptors telling me, hey dude, we're over here, we're bent this way, we're doing this thing, and when I do something fast, proprioreceptors stop me from throwing my shoulder out of socket and all that kind of stuff. They tell me how fast, how much pressure I'm putting on joints, where they're bending, how far they're bending. And they're literally the reason why you kind of know you're standing here with your eyes closed. It's not because you can see yourself. It's because your proprioreceptors tell you, like, I'm feeling the floor this way, I'm feeling gravity this way, I'm bent this way. That's proprioreception. We take it so for granted, it's hard to convince people what's going on. Like you're doing it all the time. But it's actually quite amazing that I know that my arm is over here without looking at it. And you're like, well, of course you feel it over there. That's my point. You feel it over there. That's proprioception. Yes, Miss Monreal.
So I guess, okay, so does this fall into that category? You know when you're sleeping, but you know somebody's like sitting there watching you. Is that different?
That's
because,
different.
Like, you feel something that's different?
That's different. That's your creepy receptor.
So it's just like in reference to yourself to other things, correct?
It's just in reference to yourself. It's your body's, it means a lot of your nerves are just maintaining where you, it's the ability to see where your body is in space.
Okay.
Yeah. It's the thing that lets me know, like, obviously if I turn my head this way, I know I'm turning my head this way because I can see over there. But I can turn my head that way with my eyes closed, not see over there, and know that I'm looking over there. That's proprioception. It's because receptors in my neck are saying you're turning, and they're even telling me how much I'm turning. I know the difference between this and this, dramatically. I even know how fast I'm turning. That's proprioception. And it's important for a very, very important reason. So that's proprioceptive neuromuscular facilitation. Well, those receptors stop me from stretching sometimes, and those receptors get set too short. And here's what I mean. Let's take our guy at the office again. Remember him? He's at the office. All day long he's sitting like this. All day long my iliopsoas is short like this. All day long my rectus femoris is short like this. All day long my sartorius is short like this. All day long some of my adductors are short like this. All day long my gluteus minimus, maybe medius, is short like this all day long, yeah? I get up like this. They're actually long enough for me to straighten up all the way, but my proprioceptors say this is very different from what we're used to. We should stop the stretch right here because we're worried about tearing. Proprioceptors keep you from tearing yourself and things like that. But I can go further. I've got length in them, but they're just so unused to that length being tested that they're stopping me. Well, there are ways to reset your proprioceptors so all of a sudden they go all the way back to normal. If their length is actually there, you can actually get them to use to their full ability. Most of us have more range of motion than we're experiencing. Our proprioceptors have been set a little bit short, sometimes a lot short, because of our lifestyle. And proprioceptive neuromuscular facilitation uses active assisted, and then what I'm going to talk about active resisted, active resisted, and what I'm going to talk about active assisted, techniques to get the client to reset their proprioceptors so they can move further. So let me tell you how that works, because PNF stretching is probably one of the most important things in massage therapy, especially in structural massage. What did Mr. Tapscott say? He said he's about to tell me about one of the things that is the most important thing to know about structural massage. PNF stretching is one of the most important things to know about massage. Okay? Ms. Monreal, you have your hand raised?
No, sorry.
That's okay. Anyway, PNF stretching is one of the most important things to know about massage. And because it allows you to reset, clients' limits on movement, and that can change everything. And here's how it works. But before I tell you how it works, there's 47 different versions of it. So you're gonna meet somebody and be like, oh, I learned about PNF stretching, and they're gonna be like, well, I do CCRQ stretching. I do XYZ PDQ stretching. I do RCIBB stretching. Whoopie-doo-dah. They're all versions of PNF stretching, trust me. They have to do with whether the client resists or assists, how long you hold it, all this kind of stuff, but they're all based off what I'm going to tell you right now. All of them. So I don't even do exactly PNF stretching, but I use that basis, and you're going to hear how it works. You have stretch reflexors in your muscles. And what they do is, let's look at, what's the muscle, by the way, that goes from here to here that allows me to flex my elbow? Please tell me, somebody.
Bicep?
Biceps. Biceps what? Because I've got a bicep in my leg.
Biceps brachialis?
Yep, biceps brachialis, biceps brachii. Biceps brachii, underneath it is another muscle that also helps me do this too. What's that one called?
That is the Is it brachiole?
Brachialis.
That's also called okay.
Well, this is
So
bicep.
the biceps brachii and then the brachialis.
Yes.
Okay,
Biceps
thank you.
brachialis.
Sorry.
They're both mainly, there's some other muscles, by the way, we haven't learned about yet that help me do this too, but these two are the main ones that let me do a flexion. So if I'm having a hard time doing an extension, if I stop right here, I haven't gotten to bony end feel, I'm feeling some springiness, but I can't go any further, those are the two muscles that are short. Right? So I can trick my client into helping me stretch them further. So if I just push against...
like assisting?
What?
So is it like the client's assisting you into their stretch?
Yeah, and let me explain why that works and the type of assisting, because there's active assisted and active resisted. Both are assisting, but they're doing different things and they have different effects and they both work really well. So regular stretching, I'm just pushing against this. The client's passive. I'm pushing against this, trying to get this to stretch out. That works. But what happens is the client has a stretch receptor called a Golgi tendon organ that's saying we've stretched too far here and we're worried about tearing. And I'm like, there's no way they're going to tear there. So what I do is I have the client actively resist me. I'm trying to stretch them, they pull back in. Now I tell them to only do it with 10% of their power. I don't want them to win. I just say with 10% of your power, press back in. Some of you have to tell 5% of their power because they try too hard. And they pull back in and you count to 10. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And then you tell them relax and then you push. And you usually go a little bit further each time. The reason that worked is what happened was right here the body's going, I've got all this stretch right here. I don't think I should go any further. I'm feeling all this stretch right here. When they resist, they actually pull against the stretch sensor even harder, but nothing happens. And the body goes, oh, I guess we can handle more stretch. The muscle's strong enough. It's safe. We just didn't realize that. And so it lets you go further next time. So it was experiencing like 50 pounds of pull here when the person pulled against you was experiencing 60 pounds of pull. Now it thinks it can go further. So that's essentially PNF stretching, but we're going to add some more to it to make it even better. There's something in your body called reciprocal inhibition. Does anybody know what reciprocal inhibition is? It's okay if you don't. Reciprocal inhibition is this really cool thing that goes on. You can override it, but it's a really cool thing that goes on. My body knows that when I am doing a bicep curl, yeah? What muscle can stop this from happening? What muscle do I not want to be firing right now while I'm doing a biceps brachii and a brachialis curl? What muscle would stop this? What muscle is the... Who said it? What?
Triceps.
Triceps. The muscle in the back of my arm actually pushes my arm out. My body actually, when I'm using my biceps, sends a signal to my triceps to shut off. And when I'm using my triceps, it sends a signal to my biceps to shut off. That's called reciprocal inhibition. It can be very useful. So, think about this for a second. If I'm pushing the client out and I have them help me push them out, what muscle are they activating if they help me push them out, if they help me stretch? What muscle is the client using if the client helps me push their arm out?
Tricep.
Tricep, which sends a signal to what to release?
Your bicep.
Yes, and what am I trying to stretch?
The bicep.
And I just sent a signal to it to release. So we just used these two things that your body already, in fact what we did was we combined regular stretching with active assisted stretching with active resisted stretching. Here's how it looks. I stretch the person here. I go, that's as far as they go. I hold this though. I say resist me for 10 seconds. They resist. And I say let go. And I push them further. Every time they go further, really. It works brilliantly to reset that stuff. So that was active resisted. They were fighting me to put extra pressure on the bicep and get it to kind of, once they let go further. This time though, after I say, hey, resist, and I stretch further, I say, now help me stretch. They kick in their tricep, and that shuts off their bicep, and they tend to go further still. And then I say, now relax again, and I hold it here for a while. And then we repeat that process. That's like turbocharged PNF stretching. I'm pausing because it's actually one of the most important things I can teach you. Deep tissue, along with PNF types of stretching, is some of the most effective stuff that you can do. Yes, Miss Hunter.
Okay, so I understand what you showed us. I've never had that done, or maybe I just didn't realize it when I go to massage therapist. Is that something? It's not common, is it?
It's not common. You're right. It's not common, but it's kind of like commonly known. It should be common. I don't understand why it's not common. It is common with really good therapists. So
It's common in like a sports setting.
Yes. Thank you. That was a really good answer. Much better than my answer. It is common in a sports setting. They tend to know about it more. Miss Monreal.
I first learned about it in track.
Yeah. It's common in sports settings. Yes. It makes perfect sense. Yes. Very good answer. Thank you, Mr. Kandars. It's very common because they kind of get the whole concept. Miss Monreal, you were going to say something?
Yeah, I was going to say something along those lines that is common in more of like a clinical setting.
What do you mean? Just say it.
The book.
Huh?
Take
Did
my
you hear
book.
me?
No, I'm sorry. Mr. Barr just took my book. Okay. What were you saying?
I was just kind of saying something along the lines that Jack was saying, that it is more common in more of a clinical setting.
Yes. Yes. Yeah. And by the way, let me be clear. If a client comes in and says, I just want to relax today, they don't want to be helping you lift their legs. I mean, I was using my arm as an example, but you're usually using this on their hamstrings and quads and their iliopsoas, things like that. They don't want to be fighting you and playing with all that stuff, and they're like, they're just not into it, and that's fine. But when somebody comes into me and says, I've got severe back problems and I think their hamstrings are shortened, I'll massage their hamstrings, but this is something I will use directly if I have an active client to stretch out their hamstrings and get further movement on them and help give them some real relief. So you're right, it's something you use in clinical massage, which is why it's in the clinical section of your textbook. Ms. Petrie, you have your hand raised? Yes, ma'am.
I just wanted to ask if a client had damage of any kind, would you still do a kind of stretch like that? Like significant damage, if they tore something in the past and it's...
Oh, well, if they tore something in the past like a month ago, I would do it.
Okay.
Because I figure, okay, you're healed. In fact, this is one of the situations that happens. Thank you for asking this. But if they tore it a couple days ago, no, you're right. Because I don't want to put extra stress on torn tissue. But we tear stuff. I tear my bicep in the past. Now I'm protecting it. Right? So I walk around with it like this all the time. Because of the pain and because of the injury, my brain has set my proprioceptors short to protect it. They've got extra space, but it's to protect it. And I don't know I can move it out further, and this type of PNF stretching is excellent for opening stuff up like that people are protecting. Yes, Ms. Petrie? No? Yeah.
It's more of just I mean, I could talk to you more about it later. It's more of like a personal thing, but my brother just tore his ACL completely. And now he has to get complete surgery for it.
Yeah, I wouldn't do it on a complete tear.
I mean, obviously right now this isn't something that I'm not even working on him. He's not even a client right now, but I'm just saying in the future, maybe this is something that I can learn to do with him to try to get strength back into that area. Would that be?
Yes, that's the other nice thing, by the way.
Okay.
The other nice thing is it is a great way to build up some strength in those areas because they're resisting you. Right?
Yeah.
Yeah.
Right.
Anyway, that's PNF stretching. And ask Mr. Ibarra if you guys can go over some PNF type stretching techniques in class. And because it's fun to play with. And it does help people bring up not only increase flexibility, but increase strength in those areas. And the only thing I wouldn't do it with is total tears and stuff, because that's not usually the problem. Your brother's problem isn't flexibility. His problem is he's torn something completely off. He's probably got incredible flexibility right now, but in the wrong way. Yeah, he's probably got bony end feel, and that's not the type of flexibility we want. This is for people where you just feel like the muscle's stopping them short. Like they just, it'd be nice if they could bend over further and touch their toes. And it's obvious there's
Right. I was just thinking further down the line, after surgery, and he's going through his physical therapy about it or whatever he needs to go through. And then maybe this would be something that I could step in and help him with to get more of his range of motion back.
Yeah, actually, I bet you they would recommend that kind of stuff. Range of motion after surgery is something that's recommended. And first, you just take them through range of motion, like wherever it stops, and you're just trying to keep the joint moving, right?
Right.
And then as it gets kind of better from there, then you put a little resistance on it, right? And that he fights you a little bit. And that starts to kind of build up the muscle and stuff, and you just kind of keep building up over time. Yes.
Okay.
You're rehabbing then. That's a lot of work. That's you kind of doing that regularly. Yeah. And him too, probably. The good news is he'll get some recommendations from like physical therapists and stuff, how much you guys should be doing that. Yeah. Yeah. Wow. Okay. I think I'm going to stop right there because we've kind of talked about this other stuff, at least in part. Yeah. Yeah, we have. Yep, we've talked about it in part, or you're going to have to read about it.